Yes, my weekend. I mean, don't have anything to talk about my weekend. It's just a normal Saturday with homework, with deadline, and
Goodness.
tasks. Yes, that is.
That sucks. I'm sorry. Need to make time go out. Well, don't go out right now. Sorry, got COVID. But school is now go back online. That's nice.
No, I can. Yes.
You know, I used to do.
Actually, I don't have to. I don't have any online lessons.
You use you know, like when COVID hit, I used to do rotation online. Like I do OB online. Wonder how that works. OB online. All I'm doing all day to spend time listening to lecture. Not really fun. But I think I'm a fan of online study. You know, save a lot of time. As long as the instructor doesn't tell me to turn on camera, everything's good. How's your weekend, Pat?
Not really. I I'm really busy for my study.
Oh, okay. Yeah, everybody's busy studying. Oh well. Seems like everybody come back. Good. How's everyone today? Everyone have fun? Did everyone tell the patient the diagnosis? Because that's what you're supposed to do today. This case is a little bit different. I want everyone to tell the patient the diagnosis beforehand because that's something that I want you guys to discuss with patient about. Because patient have grade 4 glioblastoma, so the prognosis is not really good. That's why I want you guys to have a little small talk with the patient about hospice. I wonder if you guys know what hospice is. Okay, so that's the goal today. So how many people discuss hospice and palliative care with patients? Okay, after today you guys will think about it. So let's go over the case. Let me put on my presenting screen right here. So case number 7. Yeah, we go far. 7 already. So patient profile again is a 60-year-old female coming for the checkup on her lab and imaging result. She was constantly having headache for the past few years, but she did not come to see a doctor because she thought the pain was normal. Pain is always constant and associated with nausea and vomiting. She also had 15-pound weight loss in the past 6 months, lethargy, and denies any fever, chill, night sweat, chest pain, diarrhea, or confusion. She reported having seizures recently but denies any changes in vision. Her children say that she had become increasingly forgetful and easily get agitated at people. Her primary care physician ordered a head MRI and labs. She wanted to follow up on them. So that's our patient history. So technically she having this problem for a while, didn't get treated and get imaging and labs, and we discovered that she had glioblastoma. So her past medical history is diabetes type 2, hypertension, medication include losartan 50 milligram once a day, metformin 1000 milligram once a day by mouth. She have no known drug allergy. NKDAs mean no known drug allergies, means she have no allergy to any drugs. Surgery including appendectomy and cholecystectomy, hospitalization 3 times, each one night, and also she recently had one night for childbirth about 10-20 years ago. So everybody have a history correct, I assume. Even though your job is deliver the news, you still have to collect history. HPI. Social history, she don't use any drugs, IV drug use or injecting drugs. Alcohol, she drinks 3 or 4 drinks per week. Smoking, she's been smoking since 20, 1 pack per day. So she's 60 years old now. So that's about 40 years, right? 40 years with 1 pack per day, that's about 40 pack years. Occupation, she's a bakery worker. Family history, so she have a long-standing history, a family history of cancer. Her father had lung cancer, already passed away. Her mother had history of breast cancer, also passed away. Daughter is 35 with hypertension. So with this history, pretty interesting to find out if the daughter also has some inherited cancer history. Review system beside a 15-pound weight loss, lethargy, headache, seizure, the rest is normal. Physical exam, this is her vital signs. Her pulse a little bit fast. Respiratory is extremely fast, okay, but her O2 stat is normal, so she probably just nervous from the visit. Physical exam, she awake, alert, and oriented. Most of the physical exam is normal. Do you guys know what Perla is? You guys all know what Perla is? I think we talked about it like the very first case that we discussed. Pupil, equal, and reactive to light and accommodation. So technically it's normal. You shine the light on the patient eye and it's react. So workup. We already do her workup. We do her labs and her MRIs. Her lab is technically come back a little bit. Well, her white blood cells a little bit elevated, so she probably had some infection with it, but we need to do more tests on it to find out what's going on, but it's not a concern right now. She doesn't have any symptoms. And then her electrolyte is normal, her CMP is normal, her MRI show this, and we all know this is temporal glioblastoma grade 4. Vân, can you write out what Perla means? So,
Yes, continue the presentation and I will
yes.
ask.
So this is grade 4 glioblastoma because it involves a really wide range of the tissues here. Even though it doesn't cross the midline yet, but when it's crossed the midline, it's called glioblastoma multiforme because it's crossed the midline, look like a butterfly. Technically, the prognosis for this thing is 6 months or less, so not really good prognosis. We can do surgical resection, but if you resect the whole, like this part right here, definitely patient will be left with some neurological problem because this is part of the temporal lobe of the brain. And look at how it's involved. Chemotherapy may get rid of this, but I don't think it can get rid of this large piece without it's growing. So technically patient have really bad prognosis. So everybody tell the patient that, I assume you guys all tell the patient that they have glioblastoma. Grade 4 glioblastoma is the assessment. This is from the radiologist. All we do as a primary care physician is to tell the patient the news and think about what we can tell them. So, but one thing I want to talk about today is usually when the patient have a prognosis of 6 months or less, we can offer them two choices. One is to go ahead with the invasive treatments. Might not be a good outcome, but if they really have hope and they really want a treatment, we still go ahead and offer it to them. But another thing that we offer is hospice or palliative care as well. So what's the difference between hospice and palliative care? So palliative care is the service that we use to treat the patient, to manage their pain and symptoms, even when they in the curative treatment, meaning that if they in chemo, surgery, or anything that's curative, which may cure their disease, we can also use palliative care. Only for patients with 6 months or less. And we don't do any curative treatment. We just help them feel better. We also call hospice end-of-life care, which means that we don't cure the patient anymore. We stop any invasive treatment. We just make them comfortable as much as possible. We reduce the stress. We offer counseling. We offer religious support to them. Probably they don't do that in Vietnam, but over here in America, we offer religious support, which means we send out a pastor and a priest or a monk to whatever the patient religion is to help them emotionally and religiously to stabilize. They all in common. Both of these services are both comfort care and reduce stress and symptom relief. Okay. However, palliative care usually be used in any setting, like even if you do surgery or cure patients. But technically it's not used along with curative treatment, but We usually call the branch of medicine hospice and palliative care medicine. So if your patient is determined 6 months or less, we usually offer hospice to the patient because we know that they probably don't have much time left. So we want their remaining time to be as fruitful as possible, as much fun as possible, less suffering as possible. Technically, we don't guarantee how long they will pass away or how much time they have left. That's the hardest question I ever get when a patient asks me, how much time do I have left? I usually tell them, I don't really know, but based on the data and according to everything that I have here, I think that you have about 6 months left. Okay. Sometimes patients in hospice and they live more than 6 months. Sometimes they're in hospice for only like 2 weeks and they pass away already. So it's all. So I wonder your hospital offer hospice service, but I think this is new and not so many hospitals in Vietnam offering that. Even hospice center. Okay. Over here we have the center dedicated for hospice, which means patient can go in there, stay in there, and pass away in there. We handle everything from pain control and everything. Usually patients in hospice, they know what's going on. Most people still seek curative treatment, but if you're in hospice, you usually accept what's going on. One more thing about hospice is if you're in hospice, you can get out of hospice and seek curative treatment if you want to. If you think that, hey, hospice is useless, I still want to be cured, you can go out of hospice and get treated. But if you want to go back to hospice again, you have to have an evaluation from all the physicians again. So just a brief introduction about hospice. That is another option that you guys should think about when your patient have a terminal diagnosis, like glioblastoma is considered a terminal diagnosis, or pancreatic cancer that unable to be treated. Think about it. Of course, this is new in Vietnam, I know. I've read a lot of things about hospice and palliative care in Vietnam, and apparently it's not really it's not really well known. Most patients in Vietnam also want to go home and pass away there, so they don't really offer hospice. However, hospice also have home health nurse, which come to the house and helping the patient. Like when my grandfather passed away at home, we have a nurses come in every weekend. This is in Vietnam. One of the hospital offers, I think it's in Củ Chi, but I forgot what's the name of the hospital. But they offer a service that they send nurses to my house to help my grandfather with his daily activities, changing his diet, changing his catheter and everything until he died. So maybe that's another form of hospice, but technically hospice is any service that provides to the patient with the prognosis of 6 months or less, okay? And there's no curative treatment. That's all about hospice that I want to talk to you guys about. Next time, if you have a patient with a terminal prognosis, maybe you should consider talking to it about it. It's worth discussing about it with them. Okay, so this is the scale that we use to evaluate the patients when they're in hospice. Of course, 0 is dead. So usually hospice patients are having a score from 70 to 0. Some patients are really healthy that they're able to care for themselves, but most of them are about 50 and below. And we have when you are joining the hospice service, the very first day the nurses will come to your house and evaluate if you are able to do work, and they will offer you any service if needed. Okay, so they will do that. So this, you don't have to memorize this. There's nothing to memorize. Don't memorize this. Okay. Any question about hospice and palliative care in general?
It gives me. I want to ask that we do palliative care or hospice care is depend on the patient, right?
Yes, patient choose, but we should offer it. We should talk to them about it. Most clinicians I see really reluctant and don't want to talk to patient about hospice, but we should have that option for the patient to discuss about it. I think it's a good thing to have.
if we tell them about hospice, we have to tell them that they only have like 6 months left, and I really have have problem to
I know
tell a
everybody.
patient like that.
Yeah, everybody have problem telling patient, hey, you have 6 months left to live. That's hard to tell patient. I don't even want to tell a patient that. But think about it. Do you want the last 6 months of them to be painfully treated in the hospital without any curative treatment and just having chemo and all these painful radiation therapy, and they know that they don't have hope left? So why not make the last 6 months better for them to enjoy the last couple of months of their life? Let them pass away in peace, you know? So we only offer this service if we think that there's no curative treatment left. Okay? Of course, we have to try everything. In our tools as a clinician, we have to try everything. However, if the outcomes, the risks of all the treatment make the patient feel worse, maybe hospice is a better option. I talked to many patients, and they told me that they wish that their clinician talk about hospice earlier, because in the last couple of months of their life they've been affected by chemo, so they're tired, they don't have energy to do what they love the last couple of months of their life. They don't even have they're not even themselves with all these treatments. So maybe when you determine, you are the doctor, you are the nurses, you are a pharmacist, maybe you are the one to determine when this patient's hospice appropriate, because I trust in your clinical reasoning that you know when to stop the treatment. Because sometimes some clinician going overboard and treat the patient, they think, oh, I cannot stop because there's maybe a hope. Well, you have to use your scientific reasoning or the scientific evidence that support that. Is this treatment really good, or is this treatment just bring more harm to the patient, and it's time to stop and offer them hospice instead? So this is all based on your clinical judgment. When did you think you can stop the treatment and offer a patient hospice and palliative care instead? I'm not saying that you have to always offer that. That's not a good thing either. You know your clinical judgment. You know when to stop. Let's say a patient have brain injury and be unable to live with their daily life. What's the point of continuing treating? Maybe make the last 6 months of their life a better end of life period. But you have to use your clinical reasonings and see when is hospice appropriate. I hope that answered your question. Any more questions? So we're not done yet. I still have one thing that I want to talk to you guys about. So today we deliver bad news to the patients. How did you guys do it? Did you guys tell the patient, hey, you have glioblastoma? Is that what everybody do? Hey, you have glioblastoma. You have 6 months left. Is that what you guys do?
Yes, I kind of want to ask you about this.
Okay. So
yes, I kind of tell her, that in a straight way like that.
Okay.
I just said that here is your MRI image, and it's very much likely to be grade 4 glioblastoma, and I know it's straight, and it's like where it sound hurtless, but I really don't know. I never in any type of situation like this before.
You will encounter this situation in the future. I bet everybody will. Everybody here, regardless of your profession, nurses, medical students, doctor, pharmacist, one day you will encounter the situation where you have to be the one that tell the patient bad news. Sometimes the bad news is on the patient alone. Sometimes the bad news is the news of their relatives. Okay, like for instance, the other day that a patient of mine, he's not dead, but he come in the hospital. I know him, and his son is the one that died from COVID. Okay, I was the one to tell him that, oh, your son's dead. But of course, I don't tell that, hey, your son's dead. That's not the right way to do it. There's not really a correct way to do this. It's based on what you think is the correct thing to say. But the American Academy of Family Physicians have a formula that may help you organize your thought about what to say. So I don't know if you guys want to take note of this, but probably don't, because this is just a discussion and conversation between me and you, that telling how to break the bad news. So the first thing you need to do is prepare yourself, because as a clinician, you know the best of what happened to the patient. So you should prepare yourself, like give yourself 5 minutes, prepare what you're gonna say in your head. Okay, I need to tell the patient this bad news. I need to tell it in the way that he or she can understand, and I need to tell him or her in the way that I'm not offending them. Okay, so first thing you need to do is prepare yourself mentally. The second thing that you need to do is set up the private environment, because nobody wants to hear the bad news in the area where so many people is around. Okay, this is just the SP and you, so of course you got in private area already. But if it's in the hospital, you may want to pull the patient aside to the corner where nobody can listen, or in the private room and talk to them privately. That's the second thing you should do, private. The third thing you should do is do not say anything like, hey, I understand this is what going on. No, you can never understand the patient, what's the patient going on. So do not say that you do understand that. You just say that, you say something like, hey, I know this must be very hard for you. Let me know if I can offer any help for you to overcome this situation. Okay. In the case that the patient family dead, you can offer them, hey, do you want to see such and such one last time, or something like that. The next thing that you should do is allow for questions. Okay, patient definitely have a lot of questions to ask you about, so make sure you allow some time for they to ask you a question. That's the only fourth thing that next time when you break a bad news to the patient, just prepare yourself mentally. Speak in the common language. Do not use medical language. Make sure that you have empathy. And I think that once you show your empathy, everything just flow automatically. You don't need any formula to breaking the bad news to the patient. There's a whole topic on how to tell patient bad news, and that may be a different discussion. We have a lot of resources on how to tell the patient the bad news, but I think the most important thing is, regardless of what resources you use, be sincere, have empathy. You know the patient's going a hard time. Do not rush them. Give them some time during the discussion. Tell them that, hey, I'm sorry this happened to you. Let me know if I can offer any help. I'm sorry that this is what's going on. We're here to help you. So make sure you're available for the patient. I think that's important than anything else. Okay? Because one of you one day will tell the patient the bad news, regardless of your profession. As a doctor, we do this commonly, and sometimes we forgot to be empathy because we do it so common, especially during COVID, that we forgot, hey, I need to be a little bit sensitive and not just tell, hey, you got this diagnosis. I'm sorry, I cannot do anything about it. Just tell the patient, hey, I'm sorry that you have this diagnosis and this going on to you. We have this treatment available. Would you like to consider it? Or is there anything else that we can help you with? That's a good thing to say. And remember, hospice and palliative care is always an option.
Excuse me.
Yes.
This is a type. This is for the patient that have really less really not much time left in this patient. Is only 6 months. But what about the patient that they have better prognosis? Maybe they have better prognosis. Maybe they have like lung cancer, and it's not a small tumor, but it's not so big, so they could have a chemotherapy or radiation therapy. And so how to to tell them that they have
So
a
to tell
lung
them that they
cancer,
have hope.
yeah, and you know that they kind of have some treatment available, but
I
you know
understand.
the survival rate is not so high.
Yeah, you can tell them the truth. Sometimes, in this case, you can tell them, "Hey, I understand this must be hard for you to think about it right now, but here is some option about treatment. Okay, you can either choose chemotherapy, radiation therapy, or we also offer another option, which is hospice and palliative care, which, according to the data, that we know that your prognosis is not really good. You should give the patient some time to think about it. Okay, do not rush them into make a decision right now in the office. They probably won't be able to make a decision anyway, because when people receive the bad news about, hey, I have brain cancer and I'm gonna die in 6 months if I don't do anything, or even if I do something, I may die anyway. So they won't be able to make a decision right away. But you can offer them, okay? You can tell them, hey, I understand that you have this diagnosis. Would you like to hear some options that we have offered here at our medical center? You can either do chemotherapy, you can do radiation therapy, you can do surgical therapy, or another option we offer is hospice and palliative care, because we know that your prognosis and survival rate is not good with all those treatments. Make sure you tell them that. You offer them options. I don't say that you have to offer palliative care right away. You have to offer them other options too, because patients want to hear about that.
Yeah, I understand.
Everybody, I hope you get something out of today. Today was not meant to be thinking and making a diagnosis. Today was to give you guys something that you guys can think about in the future when you discussing bad news with the patient, thinking about hospice and palliative care. Because I know that we all aggressively treat the patient. We doctor, we want to cure the patient completely. Nobody wants their patient to die, I know. When we have something, we always want to aggressively treat the patient. But you need to realize that we are humans, and sometimes we hit our limit. And sometimes we need to know when to stop. And that's important, because knowing when to stop will offer the patient the most meaningful remaining time that they have left. Having them in the hospital painfully undergoing treatments that we know may not be having any hope. So I trust your clinical judgment in the future, that you'll be able to make the correct decision and be able to offer the patient the best service that they deserve. Okay, this is all about the patient. And of course, as a clinician, when we're dealing with death, sometimes it's stressful for us too. So make sure you guys care for your mental health as well. Usually after the death of the patient, we usually be really stressful. So make sure you guys do something that can help you release those stress. You guys can talk to the counselor, or you guys can talk to a psychological department to help you guys relieve the stress. Talk to friends, families about that. So I hope today's meeting has been meaningful, and hope you guys learned something from it. Any questions? If not, you guys can go ahead. I think the prognosis is dependent on stage cancer time. Of course, we don't give the patient accurate prognosis. Or this is just a simulation case that I tell you the patient had 6 months left after so many research. But the prognosis, definitely we can never tell the correct prognosis. We can only estimate it. That's why I tell you that sometimes patients in hospice, or they have prognosis 6 months left and they've been admitted to hospice, sometimes they overlive their prognosis. They live for a year. We'll still keep them in hospice because we don't know, maybe after a year they pass away, who knows. But usually the hospital limit time is 2 years. If they survive for 2 years, we discharge them from hospital and we continue with their regular treatment. But of course, as a doctor, we can never tell what the prognosis is. We can only estimate it to the patient. So usually we estimate it. We just tell them, hey, according to scientific data and according to all the treatment that you go through, I think that your prognosis is not really good. would you like to consider hospice? Something like that. And yeah, of course, you're right. We can never know what the prognosis is, but usually the pathologist will be able to tell. Does that answer your question? How many of you have dealt with death in the patient before? Have you ever break the bad news to the patient before? During COVID, I do that multiple times. So well, but think about maybe in the future, you might have an opportunity to do that. And remember, it's not a bad thing to do. It's a meaningful thing to do. Okay, you've been given an opportunity to help the patient family understand what's going on with their other members. Okay, Ang, does that answer your question? Is anybody else having a question that I can answer? So today's case is easy. Next week case is very interesting. Okay, next week case, well, Dr. Toon will be hosting that case, but I will be the one who write it. So next week case is very interesting and requires a lot of thinking. So let me tell you to go and review your neuroanatomy before next week case, okay? Next week is neuro. So Toon will do that. I will write the case. Just tell you guys beforehand, let's go review your neuroanatomy before next week. I mean, not next week, in 2 weeks.
Yeah, next 2 weeks. Yep.
Yeah.
Correct.
It's really fun. I think it requires a lot of thinking, but it's neuro. Everybody loves neuro, right?
No, I'm scared of neuro.
Maybe after that case, you guys won't scare of neuro anymore. Who knows? You know,
It's always my weakness.
yeah, I have a good sources for you guys if you guys want to think about it. It's called let me use it's a podcast that I recently listened to. I think this is very helpful for medical students and even doctors. The podcast is called Clinical Problem Solver. If you listen to this podcast, they're really short. Usually it's like about 15 to 25 minutes. Okay, they're really short and they discuss cases. And these doctors in really well English and they speak really slow, so you guys can definitely listen to this. And they discuss medical cases in real time. Okay, real life cases. And sometimes some doctor will give you a schema or method of how to think about a chief complaint, like patient coming with headache, what you need to think, what do I think about. They will give their opinions on how to think about problem. I think this is very helpful if you have time to listen to these once a week. It's okay. This will definitely improve your English and your clinical diagnosis skill. I definitely think it's helpful. I never recommend anything that's not helpful. So
is it on Apple Podcast or
on
Spotify?
Pandora, I think. It's on Apple Podcast too, I think. Spotify is what it's on. It's free. You can just download Spotify and it's free on this one.
It have on Apple Podcast too.
Okay, perfect. I didn't know that, but now I know. Yeah, but it's free. Anything free is good.
Yeah, it's free.
I love free stuff. And free but good quality stuff. This is the one. Make sure you click on to those couple of beginning cases. That's where the short cases. Recently they have like an hour case, and I don't think you guys have time to listen to an hour case. But 20 minutes, 25 minutes should be good. Just do it once a week. I do it every time I drive. So all right, guys.
Thank you.
Enjoy your night, and hopefully you guys have a good time today. And remember that what you learned today might make important in the future. I know that I'm thankful for everyone being here, and I'm thank you guys for doing what you guys doing. I know that not so many people thankful for what you're doing, but remember, everybody appreciate what you're doing as a medical professional in this hard time. Okay, whether you are a medical student, pharmacists, nurses, or doctors, just know that someone out there is thankful for your work. Okay, so thank you for doing this, and thank you for being a medical professional. This week is also a nurse appreciation week, so make sure you pass by, say hi to your nurse, and say thank you to them.
Thank you for your help.
Yeah, thank you. See you guys next 2 weeks.
See you guys in 2 weeks.
Sorry.
Okay.
Wait, Vân has something.
Before we end this case today, can we take a photo so I can
Okay, yeah, everybody turn on the camera, smile, take a photo, please.
Yeah, so can you guys turn on your camera? Yes.
Cool, everybody look good today.
So who will take the picture? I will take it. Okay.
Yes.
Alright.
Smile.
So just smile. 1 second. Let me check it. Is it good? Like any problem with that?
Wait, why we have one person want to join right now?
Oh, come on. Alright. I think that everyone really nice. So yeah. Thank you so much. See you
Thank
guys
you.
next 2 weeks.
See you in 2 weeks and hope you guys enjoy today.
Thank
Mm.
you.
Alright.
Nice.
Bye.
Did I hear something?
Mm.
Okay, and stop recording, yeah.